We're really pleased to be talking about this aspect of safety. And I love the title that Kate came up with, The Safety Net We Forget. So as Charlotte said, there's three of us speaking today, and we're going to be swapping between each of us. Next slide, please. So when it comes to patient safety, it seems to me that we're often looking for that one intervention, that one thing that's going to make all the difference, the particular checklist, the particular thing that is going to transform care so that it is safe and that patients are not put at risk. It has felt to me, looking at the sort of bigger picture of patient safety, that this feels very much like looking for the silver bullet. And 10 years ago, in 2016, I was working at the University of Southampton. My career has been very much about nursing workforce things, but I was invited to join a all-parliamentary group, scientific committee, I think they call themselves, for an evening session that they were having on patient safety. I wasn't speaking, but just was joining actually because my boss at the time, Jessica Corner, couldn't make it. So I was standing in for her. I was really excited to have that opportunity to go up to the Houses of Parliament and to be part of this discussion and hear some great people speaking. So there was a speaker there from Mary Dixon from this institute, and various other speakers, and had a really stimulating discussion about patient safety. And then there was it was an after time to have supper and kind of have a general talking through things afterwards. And in the kind of open discussion section of that meeting, I found myself feeling very struck by the fact that only the year before, we'd been involved in producing, when I was still working with Southampton, we've been involved in producing guidelines for NICE about nurse staffing to ensure safety. And in this full parliamentary group, we've talked about all of these reasons why patient safety can be overlooked, or the different problems where risks are taken, and that, you know, the Swiss cheese model and how those different holes in the cheese can create danger. But what seemed to be missing to me was some of the findings from the research that I've been involved in. So when I put to that group, if you knew of a solution or a drug that wrongly applied was killing or leading to avoidable deaths with a significant proportion of patients each year, if you could correct how that drug is applied, if we could find evidence that said, actually, this other drug or this drug used in a slightly different way can save this amount of lives, would you want to know what it is? And of course, there was very widespread kind of interest. Yes, what is this thing? When I pointed out that actually this thing that potentially can save many lives and make a big difference to patient safety is nursing, that we have evidence that nurse staffing makes a difference to patient outcomes, and that insufficient nurse staffing puts patients at risk, came as quite a surprise to everybody around the table. And equally what came as a surprise was that that we were so often in situations that were putting patients in this kind of risk. So hence, for me, why it's so important that when we talk about patient safety, we don't just think about specific one-off interventions, but understand what the role of nursing and the registered nurse is in this context. So I'm going to hand over to Kate now to just talk us through the structure of our session a little bit more today, but that's just setting the scene for you. Next slide, please.
Thanks, Jane. So yeah, thanks for setting the context there, and that echoes a lot of my clinical and research experience as well. which was the kind of oomph, if you like, for doing the presentation today. I know in clinical practice, it's always felt like the nurse's contribution and our constant vigilance was the element that kept patients safe, but that perhaps in research and academic and policy circles, that didn't feel to be taking the place that it should. So in line with that, we see that often patient safety discussions focus on, like Jane said, specific interventions, technology, protocols, culture, the behaviour of individuals, but far less attention is paid to who is actually delivering the safety critical work hour by hour, kind of on the front line. And I think coming to the RCN, I've only been here 18 months, and getting amongst decades worth of research which shows the role of nurses in that patient safety critical work has really been the ammunition for presenting today, and for wanting to share that message. So next slide, please. I'm going to hand back over. Oh no, let me run through the outline. Sorry, I was getting carried away with context. So the evidence we're going to run through what the evidence tells us. We're going to talk about specifically numbers, so why ratios matter, the number of registered nurses we have, the nurse's role in patient safety, the value of RNs, so both economic costs and beyond that in terms of value, beyond costs. We're going to reframe or have a go at reframing how we feel the patient safety narrative should go forward. And we're also just going to briefly at the end talk about the role of the Royal College of Nursing in setting that narrative. Thanks, Sophia. Now it's next slide.
Sorry, just there we go, unmuting myself. Yes, so it falls to me to tell you a little bit about the evidence. And specifically, we're looking at the evidence of what difference registered nursing makes to the outcomes and experience of patients. So if we move to the next slide. In a really simple, crude way, the basic message, and it's what decades of research has shown, is that higher levels of registered nurse staffing is associated with lower risks of patient death in hospital. These are avoidable deaths. So a lot of this research looks at case mix adjusted outcomes. So it's case mix adjusted mortality, and relates that to registered nurse inputs in terms of staffing levels or the nursing hours per patient day. And we consistently find this relationship, and we've been seeing it for a long time. It literally is decades. So Kane and colleagues did a systematic review of this 20 years ago. The data was then also, the studies and the research in this area were then looked again in preparation for the NICE guidance that was done in 2014 to look at what constitutes safe staffing in hospitals on acute adult wards. It's true that much of this is focused on hospitals, and there's less work on community context or mental health in those out of hospital care settings. But nonetheless, the data that is on hospitals is incredibly strong. So just to give you a flavour of some of those sorts of studies, the next slide will show you a study that was undertaken by Linda Aiken and colleagues, and that I'm proud to have been part of. And I'm just going to let that slide load. There we go. So this was a really important study for nursing and for healthcare, because this study, the Registered Nurse Forecast Study, RN Forecast it was known, looked at the contribution that the registered nursing workforce made to outcomes. Up till then, a lot of the data and the studies that Kane and colleagues had reviewed was based in the United States. So it was quite rare for those relationships to have been fully explored outside of the United States. But this study specifically included European countries. So we had, in fact, in the study there were 12 countries, but only 9 of whom had mortality data of sufficient quality to be included in this paper. And you'll note that the paper was published in The Lancet. It was a really important study because it looked at very specifically the relationship of nurse staffing levels and education levels with patient outcomes. So I think of it as an absolute classic in terms of demonstrating this relationship, and it's a much quoted finding that for every additional patient that a registered nurse looks after, it increases the risk of patients dying by 7%. Peter Griffiths and I went on to do some further analysis of England-only data to see, because what we've noticed is too often the relationship has been made explicit, that correlation between nurse staffing and patient outcome, but it's not been looked at in the round in terms of the contribution of others. So we went to look at using various data sources, including the RN forecast data. We looked at the relationship of registered nurse staffing and healthcare support worker staffing, and actually medical staffing as well. And what we found is both registered nurse staffing and medical staffing had a clear correlation with outcomes. High levels of those staff were correlated with better outcomes in terms of lower mortality rates. The same was not true of having higher healthcare support worker, so nursing associates or healthcare assistants being the norm across the UK. So you cannot, we cannot use one to substitute for the other. However, you'll notice this study is quite old, so if we bring ourselves a little more up to date, the next slide shows us some more recent research and gives you that. Let's give that slide a moment. Yeah, here we go. So, oh, apologies, little typo. Not so much new researcher, very much old researcher, in that it's still me and Peter Griffiths, and neither could be described as new, but new research. So this is a most recent study that looked in detail at 4 hospitals in the UK. And what's different about this study is it's not correlational. One of the challenges and criticisms made of the evidence body to date is that so much has been relied on correlational studies, and as I say, much of that has been in the US. Well, this is UK based, and it was longitudinal, with a longitudinal design looking at data at shift level for individual wards at individual shifts. So looking at the staffing on a particular shift and looking at those patients on those wards during those shifts. And what we find is a very clear relationship again between nurse staffing and patient outcomes. But interestingly, what we find is it's not just the number of people on duty that matter. It makes a difference whether you have permanent staff or whether you're filling the gaps with temporary staff. So filling the gaps is better than not filling the gaps, but we see a improved lowered risk of death if it's actually got permanent staff that are providing nursing care. And moving on to the next slide. This is from a different study, but it shows the nature of the relationships. So the blue line is the relationship between registered nurses and outcomes. And you can see a consistent linear type relationship. But interestingly, that is not the pattern of the relationship with healthcare support workers. So at either extreme, you've got this more of this U shape. So you've got a different pattern. Having sufficient support workers is important, but they do not, when they're used instead of registered nurses, they do not compensate for. So that's an important point to note. Moving on to the next slide. So what this means in terms of planning nurse staffing and avoiding risks to patients is we need to get nurse planning right. And it's not just about having enough nurses on the day on the shift, and it doesn't matter whether they come from another ward or it doesn't matter whether they come from bank or agency. It matters, as the previous slide and research has shown, it matters that they are the permanent staff, but it's also not cost effective to staff to the mean is the problem here. Because what essentially, when you think about it, if you only have enough registered nurses in an establishment to meet needs for like the average amount of time, then by definition, half of your shifts are understaffed. So you are routinely not going to be having enough registered nurses on duty. So it's an illusion, and it's not. This doesn't just apply to nursing. It's in the operational modelling world. It's seen as a generic kind of normal thing that everyone understands. Staffing to the mean is a fallacy. It doesn't work. But in the health service world, it's what we've done. So even when we use really good quality, I say really good quality, even when we use the best available tools to plan nurse staffing to make sure it's right and good enough for safe care, we're not necessarily getting it right because of this staffing to the mean, as opposed to making sure that there's sufficient staff on the establishments that can actually cover 3/4 of shifts and only need to use temporary staff for when those people are not available. Next slide. So, is this slide me, Kate? I can't, yeah, just checking because I can't see the numbers. I've lost track of what number we're on. Yes. So to sum up, in a way, we know there's this relationship then. When registered nurse staffing is low, we know that it relates to increased risk of patient death in hospital, but also other adverse outcomes, and that's what lots of different studies have found. What we didn't know is whether, and couldn't demonstrate, is whether one thing caused the other. However, what we did was look at what could be a plausible causal pathway. So why is it that nurse staffing would contribute to patient outcomes? And what we found when we looked at what happens when nurse staffing levels are low is that nurses then report that they can't give all of the care that they think is necessary. They know they are missing key bits of care. Important things get missed. And that it's this missed nursing care is itself the trigger for worse outcomes for patients. And we did various analysis that explored that, and also then further research has, like that study I just was talking about earlier, the longitudinal design makes it very clear that it's not just a correlation, but there is a causal relationship between these things. And just to reinforce that multiple studies have said that you cannot substitute for the registered nurse, that having more support workers does not compensate for not having enough registered nurses. Support workers are a really important part of the team, and registered nurses need them to support care delivery, but they cannot replace. And that's a really important thing, and that's something that the RCN is very clear about. Finally, that final point about the need for observation in particular, because it's something about the registered nurse, not just the interventions they do, but that broader activity. And I think the next slide is yours, Kate. Yes, I'll hand over to you.
It is indeed. Thank you. Yeah, so we're just going to unpack that a bit more. What specifically is it about what the RN is doing that's making the difference? So next slide, please, Sophia. Thank you. So there's a couple of clicks here, I think, if you could. So yeah, a lot of this work that's going on is invisible. And the nature of the work is invisible and therefore difficult to quantify and arguably difficult to describe as well. What specifically makes the difference when an RN is delivering work or labour and missing that labour? What's happening there to make the difference? And we sat talking about this and thinking about it extensively, and I think perhaps the reason some of it's invisible is that the professional identity of what nurses do, and those identities are outdated, really. They're based on outdated perceptions of nursing work, and they often relate to ideas around comfort and kindness rather than that safety critical element. So what do nurses actually do? Well, it's about surveillance and it's about vigilance, and their presence, them just being there, is what makes the difference. So we're talking about continuous monitoring, noticing clinical changes, and importantly, nuances in those clinical changes. And I think this for me is a really key point, because a lot of the interventions that are in practice that try and detect deterioration, for example, they actually the nurse being there and their presence and their experience and vigilance will step in a lot of the time before those interventions come into play. So if we think about early warning score, for example, often it's the very subtle changes that wouldn't pick up on those different interventions that the nurse notices ahead of time. So they're often kind of enacting those patient safety interventions. So that when they notice these changes, it's their judgment of whether to escalate and in what way to escalate. So we're talking about advocacy, we're talking about the articulation of any concerns, and we're talking about making sure that escalation gets delivered to the right person in the right way. And we're also talking about care coordination, and Davina Allen talks a lot about organising work that nurses do. And that's, again, behind the scenes work that ensures that patients don't slip through the gaps and they see who they need to at what point. We're also talking about emotional labour. So both managing the patient's emotions and their own emotions to ensure that patients feel safe and therefore feel able to share any concerns they might have or changes that might be relevant for their care trajectory. So we're ultimately talking about preventing harm before it occurs. Most nursing work is about preventative, relational and cognitive work that is invisible and arguably undervalued. Thank you. Next slide. So what happens then when staffing's inadequate, care is rationed? This happens quietly. These changes happen quietly. So when nurses are not, RNs are not present, so we're talking about short staffing, like Jane was talking about, we're talking about temporary staff, nurses being substituted for nursing support workers, for example, and that safety critical care is missed, or it's delayed, or it's rushed. And assessments, for example, can be rushed, so subtle details are missed or oversights are made, which should be no surprise. Obviously, you can't escalate what you don't see. So whether that's down to experience or whether it's down to capacity, if you don't notice those elements of a patient's condition, that you can't escalate or act on, can't deliver care accordingly. Like I said previously, that ability and capacity to escalate and refer, that element, that relational element, it can be missed, delayed or rushed if perhaps the confidence isn't there to escalate. Perhaps it's those informal conversations, escalating or running things by other colleagues. Those kind of conversations get missed or they don't happen. Delivery of treatment, this feels like it's slightly easier to quantify. So we're talking about the delivery of antibiotics, time-critical medications. We know that these become rushed, omitted, and naturally mistakes made when teams are under pressure, or perhaps teams are less experienced and don't necessarily understand the implications of certain medications and feel able to challenge. Comfort and preventing suffering. So we're talking about pain relief and basic needs, pressure care, for example, perhaps more traditional nursing, the elements of nursing that feel more traditional. But beyond comfort, we're talking about that holistic perspective. And when that kind of care gets delegated or doesn't happen, that ability to notice those hidden details about a patient's situation that keeps them safe. And again, they're often not glaring. I can remember in my own clinical practice, patients don't often, and I worked in emergency care, so patients were really acutely unwell, but sometimes they would present relatively well and then subtly their clinical condition would change. It's important to say that those changes are often they're subtle rather than glaringly obvious. And it's those, sometimes it's that delivery of other care around comfort and pain relief and those needs where you notice the more kind of important, if you like, elements of a patient's condition related to patient safety. Education and equipping self-care, so that communication where patients feel empowered to return or manage their own condition, often that is that's missed entirely. And it's staggering, really, because we know that this missed care, like Jane was saying, is a direct mechanism linking staffing to harm, but it's often invisible in the nature of its work and the specific contribution the RN is making, but it's also invisible in the routine data that we collect. So missed care is due to it's due to that insufficient capacity rather than poor nursing. Thank you. Next slide. So to summarise this section, RNs are the primary safety surveillance system. They're the first responders to patient deterioration, and they are the coordinators of increasingly complex care that's going on behind the scenes. And we shouldn't be surprised that safety failures often occur when this net is overstretched. So it's not just about what systems we design, but who has the capacity and the expertise to enact them in practice. Thank you. Next slide. Back to Jane to just talk about the numbers and ratios.
Yeah, and yeah, the numbers matter in a nutshell, and that's what the evidence that shows. But I think it's something that is so often, it seems so simple and so obvious, but it nonetheless gets overlooked, in that even amongst nurses ourselves, often when I present the data, which I've been kind of doing this research for several decades now, when I present that research, often the response is, oh, but it's not just numbers, is it, Jane? Because it matters, like leadership is so important, because it matters the experience of individual nurses and the mix of expertise within the team. And all of that is true. And so this is not about saying numbers is the only thing that matters, but it's saying, actually, nonetheless, having enough is the beginning. It's kind of like a Maslow hierarchy of needs. You haven't just got the basically enough people, then all of the leadership in the world is you know, you can't do it. So yeah, that's a key point here. So looking at the next slide. So this was for me a really important moment after decades of researching their staffing and relationship with outcomes, because post Francis, the government invited NICE to develop guidelines on what constitutes safe staffing. And they were going to look at each setting in turn, identified, I think it was 8 different settings, so it included community, mental health, maternity, A&E, but they started with general acute hospitals. And the wonderful thing for me was to see that A, evidence was going to be used to inform guidance on this. B, there was a recognition that actually nurse staffing was a critical component of safety. That just that wording alone, safe staffing, that didn't used to be seen that way. So that was quite a big and important thing. But 3, the third really important point for me was that we were actually going to talk about numbers. Up till then, guidance in many parts of the UK, but particularly say in England, the NQB guidance around that time talked in very generic terms about enough staff in the right time at the right place. But it didn't talk about what is enough, and it didn't talk about which type of staff. So are we talking about nurses here or someone else? So for me, the specificity to say, what nurse staffing do we need? And let's actually talk about real numbers, not just say more is better than less. So although they recognize there is no specific single ratio that could be applied willy-nilly across the board to everybody, they did flag that looking at the evidence, they did talk about numbers. So they said, actually, if you have 8 patients or more per registered nurse as an average, that is associated with a significantly increased risk of patients dying from avoidable causes. And the guidance was accompanied with other stuff about all of the other things that are needed to be done, and also said that you can't replace good nurse planning with this rule of thumb about 1 to 8. So if we look at the next slide. So how many patients then is safe per registered nurse? Well, in many ways, despite that nice guidance, there still is no limit, because that nice guidance was exactly that. It was guidance. And what we see now as we carry on doing research into this field and looking at what current nurse staffing levels look like is that actually, time and again, we have acutely ill patients being looked after in places with insufficient nurse staffing, with insufficient access to registered nurses. So that 1 to 8 is too often not being used as a red flag as it was intended. And actually we have registered nurses telling us that they often the level may be 1 to 9, 1 to 10, 1 to 12, 1 to 15. It's quite frightening how that's the case. So this brings us to the next slide. Which is to look then beyond the fact that having the numbers matter, but the fact that also there is a value in registered nurses, an economic value, as well as this clinical value that I've talked about. So I'm handing over to Amanda.
Yeah.
Am I right? Yeah.
Yes, you're right. I hope you can hear me well. So I'm going to briefly present some key findings related to the economic value of registered nurse, but I just want to highlight that it's not just about cost, it's not just about money. So we also wanted to highlight the value of nursing, that the nursing creates across patient outcomes, system efficiency, and also workforce sustainability. So the evidence shows that eliminating registered nurse understaffing is associated with a wide range of system benefits. These include reduced agency costs, fewer readmission, shorter length of stays, fewer complications, fewer litigation claims, and lower staff turnover and recruitment costs. And so, in other words, so investing in nursing improves both patient outcome, but also efficiency across the system. And there is a recent economic modeling study that using data from 4 NHS hospitals that estimated that eliminating RN understaffing would cost less than £3,000 per QALY per patient. And they also estimate that the value of reducing hospital stays, staff sickness, and then readmission exceeded the cost of paying for this additional staffing. So, meaning that in the end, we had a net cost saving. And then, if you wanted to put this into context, this intervention of reducing RN understaffing is roughly, how can I say, 1/10 of the threshold applied by NICE for cost effectiveness. So it's well below the standard threshold. Next, please. Next slide, please. So as we've been showing this in this presentation, nursing creates a clear clinical and economic value that's improving patient outcomes as well as reducing pressures on the system. But nursing also generates a broader value for society, and these include trust in the healthcare, continuity of care, compassion, more equitable access to services, and these benefits are very hard to be quantified, and they are often overlooked, especially in the scientific literature, but by no means they should be ignored or they should be considered as less important. And they should be looked at. They deserve far greater attention when we want to make a case how we value and invest in nursing. And I will pass back to Kate, I believe, that is going to talk about nursing as a solution for patient safety.
Thanks, Amanda. Next slide, please. yeah, I'll try and whiz through these just so we've got enough time for questions. But so yeah, our reflections relate to the reframing of patient safety and the plea almost that it begins with the conversations around patient safety begin with the nursing workforce. We've established, I feel that nurse staffing is a safety intervention of itself. It's a quality strategy, it's about sustainability, but it's also a humanitarian choice. If we think about the patient safety conversation and the impact on patients from a clinical perspective, we're also talking about unnecessary suffering when nurse staffing isn't right, and that becomes a humanitarian choice to not address that. So we would like nursing workforce evidence to be central, not peripheral to the conversations around patient safety. Next slide, please. Thank you. And this is a kind of closing slide that introduces a lot of kind of bold statements, but so we've established nursing work's invisible, safety work is continuous, relational, and often undocumented. Systems assume nurses will always cope and that numbers and experience don't matter, so that makes it interchangeable. Staffing therefore becomes flexible, but safety doesn't change, the need doesn't change. Nursing is framed as almost a cost, a nice to have rather than an investment. And those decisions around funding prioritise short-term savings rather than long-term quality. We know it's a highly gendered profession. Around 90% of nurses are female. We can't get away from the fact that caring labour is undervalued, misunderstood and under-recognised, and that part of understanding that is around the gendered element. And nursing lacks power in decision-making processes. We know that this evidence is strong. There isn't another profession that's studied as much as nursing is, the contribution of nursing over the last 30 years, but that the influence of that evidence is unequal. And we know that workforce voice is often missing from patient safety policy. Thank you. Next slide. I'll hand over to Amanda now, just as the closing slides to talk about our contribution as the RCN.
Yes, we are nearing the close. So we are just a few more slides to go. So for those who may not be familiar with RCN, so the Royal College of Nursing is both a trade union and a professional body for nursing. So we represent over 500,000 of members across the 4 UK nations. So it gives us a very unique role, and not only for advocating for our members, but also for shaping standards, policy, and a wider strategy related to health, safety in health and social care. So next, please. I'm just going to briefly talk a little bit more about the Nursing Workforce Academy. So that was established in 2024 to respond to this growing nursing workforce crisis. And we do have a couple of objectives. So the first one is to set the standards for nursing care and workforce planning, and also to commission, but also to conduct research in-house to inform policy change, to develop evidence-based resources to support our members to take decisions, and then influence policy to reflect the value of both nursing expertise, but also workforce well-being. So in a nutshell, so the Academy wants to use robust evidence to drive change. And in order to do that, to achieve that, we have 3 priorities. Next slide, please. So the first one, our first priority is to promote the value of safe nursing staffing as a critical component for patient safety. The second one, we focus on good work standards and workforce well-being, and recognizing that staff condition directly affects the quality of care delivered and also safety. And the third one, we develop a professional career framework, and we are trying to build consensus on the definition of nursing practice and setting standards to different levels of nursing practice. So this work is about making the nursing workforce visible, but also valued. And then I'll pass on to Jane to come up with final conclusions and reflections.
Thank you. Just going to go to the next slide. So I think you've heard from us. You've probably got the message is probably reasonably loud and clear. We think that patient safety cannot be meaningfully addressed without putting nursing workforce centre of that whole discussion, and that nursing actually is a safety net, and it's an absolutely key one. That holds systems together, it absorbs risk, and it, on a day-to-day, hour-by-hour basis, it prevents harm. But it's not always understood, and although we've got all that evidence that we've shared with you today, and much of which you're probably familiar with anyway, it's not been reflected in policy. So we still do have a situation where we have guidance on their staffing levels, we have guidance on what tools to use, and even in the countries in the UK that have legislation, it doesn't stipulate numbers. And so it's all too easy when economic pressures are applied, which they constantly are in health services, it's all too easy for nursing to be seen as a cost, not as an asset, and for nurse staffing to be cut without properly assessing the patient safety risks that triggers. So our prompt is, what would patient safety look like if we actually designed it around nursing? And actually to think about what we see as a key part of this is that we can't carry on relying on goodwill and guidance to inform nurse staffing. That even when directors of nursing and trust boards are very keen to improve nurse staffing levels, what we saw post-Francis was they didn't have sufficient nurses in the labour market to be able to fill vacancies. And what we've seen in this last couple of years, even when a government goes all out for 50,000 more registered nurses, a year later, there are recruitment freezes, vacancy freezes. So we know that it's a bigger problem and that it needs some much more robust, intractable solutions. And we think that having enforceable mandated minimums is a key part of that. I think that's the last slide, other than just to say any questions, which hopefully we've got